Welcome, everyone. We are at the top of the hour now, so we're going to go ahead and get started. Thank you so much for joining us, and welcome to today's presentation, How Primary Care Providers Can Help Prevent Elder Suicide, a new guide to geriatric suicide safer care. My name is Rick Brown, and I'm with the Association of Clinicians for the Underserved, and I'll be your host for today's training. For those of you who are new to ACU, we are a transdisciplinary membership organization uniting clinicians, advocates, and organizations in the shared mission to establish a robust and diverse workforce to help transform communities to achieve health equity for all by leading advocacy, clinical, operational, and equity excellence. We provide professional education, training and technical assistance, advocacy, and more. And we invite you to learn more about us and membership with ACU at clinicians.org. If you're interested in more resources on suicide prevention in primary care beyond today's training, we really encourage you to visit our Suicide Safer Care page. You can find a variety of resources there, including our new toolkit on geriatric suicide prevention in primary care, which Virna will be discussing in part today. And I'm also going to put the link into the chat for our page, but there's a variety of other resources as well, from our general toolkit on SSC to other things such as pediatric suicide prevention and a host of archived webinars. Before we begin, I just wanted to go over a few quick housekeeping items. First, if you haven't yet, please complete our I should say our pre-survey. It's very helpful to allowing us to assess and improve our trainings. And I'm going to put a survey link here. Second, we will be recording this session, and we will send you the recording and slides within a week of the webinar. We love engagement, and we really encourage you to ask questions during the presentation. You can ask via the chat or the Q&A as you think of them. Verna's great about being able to answer questions on the fly, so please don't hesitate. At the end of our session, please also be sure to complete our evaluation in our post-survey. It's really helpful, again, to help us to improve our trainings. Lastly, I'm honored to introduce today's speaker. Dr. Virna Little is the Chief Clinical Officer at Concert Health. She is a co-founder of Zero Overdose and an ACU Advisory Council member. She is a national authority on suicide prevention. We are excited to have her with us, and with that, I will turn it over to Dr. Little to kick us off.
Great, thank you. And thank you so much, Rick. Always a nice introduction. And if you're not familiar with ACU, I really encourage you to go to clinicians.org. Fabulous, fabulous work. So we're going to spend the next hour or so talking about suicide prevention in primary care, particularly for the geriatric population. So during the time of Zoom and COVID, I have learned to multitask, and so I will actually be watching the chats and the Q&A as we go along. So feel free to put something in there. I'm really glad to have conversations as we go along. So we're going to be talking about suicide. Certainly a great way to spend your lunchtime talking about suicide. Suicide is becoming more and more common. One of the things to know is that many of your patients think about suicide. Many of them make plans to die by suicide, and many of them will actually make a suicide attempt. And so know that many of your patients are experiencing suicidal thoughts. As we go along today, you'll hear me use certain language or terms. So just to kick us off, you'll hear me say died by suicide versus committed suicide. People commit crimes. They die by suicide. So making sure we're using the right language. Successful versus unsuccessful attempt. I've had so many people get introduced to me over the years. I'd like you to meet this person. They had an unsuccessful attempt. And what are we really saying? You couldn't die by suicide successfully. Had you been successful, you wouldn't be with us. So trying to stay away from that language. Also, language, I never pretend to know what someone's intent is. And it's always interesting to me. I get a chance to review electronic health records, and I often see in big letters in flag sections or in note sections, patient was manipulative, patient is attention seeking. And so because we don't really know someone's intentions, right, it's better for us to tell our team What did someone say? What did they do? I also know that if someone is talking about suicide, they're more likely to die by suicide. So I just start there. And also to use words like caring for or working with versus dealing with. So making sure that we're thoughtful about the language that we're using because language is so important. We're going to talk about the role of primary care providers, particularly with geriatric patients. We're going to talk about risk for suicide, how we're going to do some assessments and safety plannings, and most importantly, what you can leave here and do during the course of a primary care session with a geriatric patient. And so when we think about suicide, I always like to just sort of ground for people, when we think about the number of people that we're going to lose over the coming year, more than 50,000 people to suicide. That's an incredible amount of lives lost. And what we know is that primary care has a really important role to say. Most people in suicide prevention say really the biggest opportunity is in primary care. So there's a couple of reasons. One is many of the people who die by suicide um, saw their primary care provider within the month of death. The other piece that we're realizing is that patients who are not engaged, they don't see primary care, dental, behavioral health, no one, they resurface during the month of death into primary care, not into behavioral health, but into primary care. And so we have a really unique and special opportunity in healthcare to be able to identify people that are at risk for suicide. And one of the things that we know, and this is actually a little bit higher now, a large percentage of our geriatric patients are affected by depression, and most of them do not get care. And we do know that we lose a senior about every 90 minutes. So certainly something that we want to try to be proactive in changing. And one of the things we know is that not everybody who has depression is suicidal, and not everybody that's suicidal has depression. But certainly a large number of geriatric patients are affected by depression. And while we think of the number of people in the population who are seniors, they make up a considerable number of our suicides. And so one of the things that we know is that when we look at the 2020 data, we lost just over 9,000 seniors or people ages 65 and up. And those are just the ones that we know about to suicide. So certainly continuing to be on the rise, but the geriatric patients are disproportionately larger number of patients that die by suicide. And we know about some of the risk factors. We know that losing a spouse or a partner, becoming a widow or widower, is incredibly predictive of a risk factor for suicide. Having a history of behavioral health disorders, certainly having physical illnesses, particularly inability to maybe get around or to do some other factors. And so when we think about means of suicide, I'm going to talk a little bit more about means of suicide and means reduction, but certainly looking at different types of means sort of based on what someone's problems were. So in other words, people with physical health problems, right? As an example, have increased overdoses. And so really thinking about people and what makes them at risk, sort of based on what some of their risk factors are. I put youth in here as well, just because I knew we were going to have so many primary care folks in, and a lot of people aren't aware of how many youth we're actually losing to suicide. Some of the latest data is that 8.9% of our high school students attempted suicide. So certainly staggering numbers, and I always try to make sure that we're including it. So when we think about Joint Commission, CARF, HRSA, all of those regulatory folks, they are all coming together and saying, listen, you really have to think about your population of patients at risk for suicide and start to think about ways that you can, as I say, wrap a warm fuzzy blanket around them, right? And start thinking about your systems. So this is a very famous Swiss cheese slide from some of the zero suicide work. And there are places where patients fall through the holes in your Swiss cheese. So as an example, there was primary care practice, lost someone to suicide. That person actually called and had canceled multiple appointments that were scheduled kind of close together. But the person answering the phone didn't know they were at risk for suicide, so didn't know to do anything different. And there was no system in place that said, hey, this person is at risk for suicide. They've canceled these 3 appointments. Maybe we need to do something. And so that's a prime example of where people oftentimes will fall through the cracks in practices. And so if you've had an opportunity to go to the Zero Suicide website, I strongly encourage you to do it. It's got lots of systemic approaches and things that you're able to do to really address suicide across your practice, across your organization. So this project and this presentation is actually part of a larger project where we've gone around and we've trained, I don't know, Rick and I would probably have to really think about it, but it's well over 3,000 primary care providers and their teams across the country in like 29 or 30 states at this point. And of course, we'll share copies of the presentation as we send it out afterwards. And so there's a couple of things we heard. We heard from primary care providers that, hey, I do think it's part of my role, but I never got any training, which most of them did not. More than half of them said they hadn't gotten any training. And so we also heard a couple of other different themes. The first is, I don't have the knowledge, right? I don't know what to do. I didn't get training. I don't know what to do. And so there's one thing that but things and is hope. Hope saves lives. Giving people hope saves lives. And so what I'd like to do is to have you all think about a time in your life when you had to tell someone something or you decided to tell someone something and you weren't really sure if you should tell them. Maybe it was the first time you've told anyone. And that initial response from them, that first couple of seconds, really dictated, did you feel sorry you told them? Did you regret it? Did you stop talking? Did you feel like, oh, I'm really glad that I shared? And we all have those experiences or have had that experience in our life. So think about somebody who maybe just told you for the first time that they're thinking about suicide. And maybe it's the first time that they told anyone that they're thinking about suicide. How difficult it must be, and how that initial response from the person that they're telling can make all the difference in the world. Do I regret it? Do I feel comfortable? Will I tell people about my thoughts of suicide? And so what I encourage people to do is to do what we call storage statements. So storage statements are these things that I came up with when I actually used to train students. And sometimes they would get a little discombobulated when they were working with patients. They were social work students. And so we came up with some things that they could say, like just very generic statements that could just give them a moment to get back on track. And what we found is that it actually works really well with suicide patients as well. So if you think about what do we want someone to know? So if someone just told us that they're thinking about suicide for the first time, what do we want someone to know? We can throw some things in the chat. So what do we want someone to know? We want them to know, I heard you. Thank you for telling me you're thinking about suicide. And we want to say suicide, not thank you for telling me what you were thinking. Thank you for telling me you're thinking about suicide. I heard you. That we want to be supportive. You matter to me. Love that. Your life is very important to us here at the center. Your life matters to me. Absolutely. And then what do we want to do? We want to give someone hope. I have hope for you. I know how much courage it took to be able to tell someone that you're thinking about suicide. And so tonight, when you're brushing your teeth, I used to say on your commute home, but now that we're all home and we're commuting through our living rooms, I say brushing your teeth. So tonight, when you're brushing your teeth, take a minute and think about 2 or 3 sentences that you could have as your storage statements to be able to tell people who just told you that they're thinking about suicide. And so I've had providers reach back out to me and say, I listened to you talk about storage statements and I didn't do them. And I was really glad that I remembered yours because a couple days later, someone came into my practice and said to me, I knew this was going to happen. I had a rope this morning. I should have hung myself. And having those storage statements was really helpful. And so I really encourage you to take a couple of minutes and come up with 2 or 3 storage statements that will be helpful for you so that you can not panic. You can listen carefully. Thank you for telling me you're thinking about suicide. Your life is very important to me. I can see you've been through a lot and I can see the strength in you. Your language really matters. And so making sure that you're really thinking about those. So when we think about identifying people at risk for suicide, there's a couple of things to keep in mind. First of all, not everyone who dies by suicide has a mental illness at the time of death. That's very different than how we used to think. And so many people, social determinants play a role, right? The housing, the relationships, financial problems, all of those pieces. We had a primary care provider in upstate New York actually had an older gentleman and he was having some significant health problems and was not really able to work as much. They started to have financial problems. His longtime relationship started to struggle. And he died by suicide. And the provider said, I talked to him, my team talked to him, we reached out to him, and we never once asked him about suicide. But when I think back and his age and the social determinants, he was absolutely at risk for suicide. So social determinants play a huge role. And you can ask people because we know overwhelmingly in the research that asking people doesn't give them ideas. So many of my patients who struggle with, housing and finances, like you talk to me, start to think about suicide. I'm wondering if you're thinking about suicide, right? So that we should ask people directly what we want to know. I used to work in family violence, and a lot of times providers will say, well, I ask patients if they're okay. That's very different than asking them if someone's hitting or hurting them at home. So we want to ask patients what we want to know. Are you thinking about suicide? Many of my patients who I talk to think about suicide. We also know that many offices are screening for depression, and that's really helpful. But again, many patients who die by suicide don't have depression. So really thinking about your screening and making sure that you're talking to anyone. Certainly, alcohol and substance use play a huge role. Also, transitions. Oftentimes, we think of a transition as just a discharge from the hospital. But actually, transitions put people at risk for suicide, particularly in the first couple of days and within the first 30 days. And so, really redefining transition, right? So, coming out of a psychiatric or medical hospitalization, a physical rehab, substance abuse treatment, foster care, incarcerations. Those transitions are incredibly risky for patients, and many practices will actually ask people automatically about suicide who are going through transitions. The other piece to really think about is your population of patients at risk for suicide. And so, oftentimes I ask organizations, tell me about providers, tell me about your diabetic patients. And they're so proud to tell me, well, we have this registry and here's our average A1Cs and we have this educator and we have all these things in place. And then I ask them, well, tell me about your patients at risk for suicide. And it's just crickets. And so really encouraging you to think about your population of patients at risk for suicide as a population. So fortunately, we live in a world where there's a code for everything. I'm currently right now sitting in South Carolina. If I went outside, right, and my water skis catch on fire, a bat fell on my head, there's a code for all of those things. And so there are codes for suicide risk. They should be on your problem list so that they're there as structured data. You can resolve them if someone's not at risk, but it's nice to see it there historically because someone who was at risk for suicide is always going to be a little bit more at risk for suicide during their lifetime. And it will also help you think about two different populations. Many times we spend lots of time thinking, what do we do if somebody answers yes to a screening question or, says that they're suicidal? But we don't actually think about what happens when they come back for a primary care visit. So if I have an elderly patient and they say, my wife passed away about 6 months ago, and all I want to do is join her. I don't want to be here anymore. Every night when I go to sleep, I just wish that I could go to and this would be over and we could be together. And so when someone then, what are you going to do when they come back, right, for primary care? So we have systems in place for other chronic illnesses that we ask about. So I always say, I'm diabetic. When I go into the primary care office, they do certain things based on the fact that I have diabetes. So what are you going to do differently based on the fact that someone could be at risk for suicide? And really make sure that you're at least asking someone if they're safe and really giving people language. People don't mind if you put suicide risk on the problem list. It's about saying to someone, thank you for telling me you're thinking about suicide. You're really important to me. And I just want to let you know that I put our conversation about suicide and your suicide risk in the chart because every time that I talk to you or my team talks to you or I see you or my team sees you, I want to make sure that you're safe. And patients are fine. They actually like the fact that someone is concerned about them and is going to check in on them and make sure that they're safe. So I know many of you are using the PHQ, particularly for your patients, your senior patients. And oftentimes people will ask me about using the PHQ, for seniors, and there's a couple of tips. So oftentimes it's hard to remember, 2 weeks back. And so I will try to remember events, since July 4th, or since we had that bad storm, or since that very rainy day, or since, we had the parade, like whatever event that people might know locally, or a holiday, I try to do like since that day, so that they can get a little bit grounded in the time frame. It's also hard because many seniors are experiencing some chronic pain, and so they have difficulty sleeping and, some difficulty eating. So really trying to tease out. But what I like to do, particularly around suicide, is whether the PHQ is in front of me on paper or I'm looking at it on the computer, I'll actually look at it and say, so I see that you're having difficulty falling asleep and staying asleep, and that's a problem for you more than half of the days. And I see that you're having trouble concentrating on things like the newspaper or TV, and that's a problem for you more than half of the days. Those are probably related, and we certainly need to talk about ways that we can help you with your sleep because that's incredibly important. I also see that you have thoughts that you would be better off dead or hurting yourself in some way, and that's a problem for you nearly every day. So I'd like to start there and talk about your thoughts of suicide. So first, thank you for telling me you're thinking about suicide. You're really important to me, and I know how hard it was for you to come and talk about suicide. So what I'd like to do is just start there and ask you some more questions about your risk for suicide. And so I just transition in from one to the other. So there are a couple of tools that help with risk. There's the Columbia scale, which we're going to talk about, and the ASQ. Both of them are evidence-based tools with a few questions that help you identify risk. I like to put the ASQ up here because sometimes it's used more in emergency rooms or it's a little bit easier to use. There is an incredible toolkit on the NIMH website. So if you Google ASQ suicide NIMH, you will actually go right to that. If I get time in the end, I'll throw it in the chat. I usually cut and paste it, but I cut and pasted something else before this. And so you're actually going to get another email address if I did that right now. So understanding and being a little bit familiar. The nice thing about the ASQ is that it has a script that goes with it for nursing staff, which is awesome. All, often really helpful for people or practices to have. And so when we think about assessing for risk, one of the things we know is that not everybody who talks about suicide in primary care needs to go to the emergency room. In fact, we know that it can actually be more harmful to send people to the emergency room if they don't need to be there. And I actually worked in an emergency room for many, many years, sort of doing crisis coverage. And I can tell you that there is no magic that happens in the emergency room around suicide. And oftentimes they're asked the same questions that we could ask in an office setting. And so it's really helpful to be able to do that. And so that's really an important piece. The other thing that we really want to make sure that we do is we really want to make sure that we're addressing and understanding what risk is in primary care, and that we give ourselves permission to be able to make the visit about the suicide risk. And so oftentimes, when we're seeing patients, they come in, they have multiple things going on. And it's really important to try to think about suicide like we think about other chronic illnesses. And we don't send everybody who comes in, with asthma as an example, to the emergency room, right? Because what would happen? First of all, our friends in the emergency room would not be happy, but also what would happen is that people would say, well, they're just going to send me to the emergency room, so I'm not, I may as well just go right to the emergency room, which we don't want. Or, I don't need to go to the emergency room. I don't want to go to the emergency room, so I'm just going to stay home. And then we have people with asthma and suicide risk staying home, which is not what we want, right? But we also want to understand that a lot of what we do in primary care now for other chronic illnesses really applies to someone at risk for suicide. And so I do give an example. It's actually my husband, and he now knows I tell the story, and people have heard me before may have heard it. But we went in, to see his primary care provider because he lost his hearing, got hit by lightning, lost a good chunk of his hearing. So we were going in, and lovely medical assistant took his height and his weight and his blood pressure and left the room. And I was like, that's a little weird. And so a couple minutes later, the primary care provider came in, and the primary care provider took his blood pressure and said, your blood pressure is off the charts. And I'm not sure you're going to be able to go home. Asked him questions about some stress, some medications, a little bit of history, and said, listen, I'm going to go finish up with my other patients, and then I'm going to come back. So we didn't talk about his hearing loss for the whole rest of that visit because it was no longer front and center, right? And so, turns out an ambulance ride and a stent later. But the reality is that in primary care, we switch gears all the time. So whether his pressure had been off the charts or whether or not he had said yes to suicide, the same things happen. We stop, we get some information, we ask some questions, we come up with an appropriate level of care. We do this all day, every day in primary care. So think of someone identifying as suicide risk in very much the same way. And we assess risk in primary care practices all day, every day. And so we're going to talk about how we can do it and what it looks like. And so this is the CSSRS, or the Columbia scale. And there's a question in the chat about, is the ASQ comparable to the Columbia scale? The answer is yes. They're both evidence-based. I find the ASQ a little bit easier in urgent settings and with kids and adolescents. I find the Columbia scale is in most of the EMRs. and maybe a little bit easier with the senior population, but I would definitely be familiar with both. One of the nice things about the Columbia scale in primary care is this primary care version, and it's color coded. And so you can have workflows and processes in place for sort of your yellow, orange, and red patients. Because one of the things we know is what really differentiates risk is intent. I can think about suicide, right? Many of our seniors think about suicide. Many of them know how they might die by suicide. But do I intend to die by suicide? Have you had these thoughts and had some intention of acting on them, as opposed to I have the thoughts but wouldn't do anything about them? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? That's the difference, is the intent. The intent is the differentiating piece. And so I have talked to seniors, and, many times, seniors are having difficulty. They're lonely, they've lost friends or spouses. They're often isolated, they have difficulty getting around. And it is very common for them to say, I wish I could go to sleep and not wake up. Or, I had a gentleman tell me the other day, this morning I got up, and I told the Lord, please take me today. If I could do anything to help you take me today, then I will do it. And so, really, then differentiating what are thoughts, what are some plans versus what is risk and what is intent. And so what's in red here really gives someone intent, and they're the folks that may need a higher level of care, may need some specialty trained eyes sort of looking at them and speaking with them and getting a little bit better sense of risk. But for your yellow and orange patients, there's lots of things that you're able to do in primary care. And so one of the first things that I like to ask is, what are some of the reasons you wouldn't die by suicide today? Because people, have certainly thought about how they wouldn't die by suicide. Oftentimes you'll hear my kids, well, yes, or my grandkids. Yes, actually, it's really important that you're thinking about your grandchildren, because young children who have someone in the family die by suicide are more likely to die by suicide. My spouse, yes, you're an important part of your spouse's life, and a caregiver, you're very important to them. Having other family, pets are incredibly important to seniors. There's a big effort around the country to go and train shelters, that if a senior came in to actually ask about suicide, pets are incredibly important. You're absolutely right. Your pet needs you so much, and they wouldn't be safe in a shelter, right? Religion is really an important part for seniors, even now, those that are still working, particularly in healthcare, their job. But very important to know what someone's reasons for living are. And the way that I think about it is that I think about it sort of like a seesaw or a teeter-totter. So if I have more protective factors and less intent, then the safer that I'm going to be. If I have lots of intent and I don't have reasons for living or protective factors, then I'm going to be way more at risk. So it's almost like you're balancing intent or lack of intent with reasons for living and protective factors, and sort of weighing them out. And I will often do that with patients, but that's a little bit gives you a way of how to think about it. So safety planning certainly is an important part. We used to do something terrible. We used to do contracting for safety. We now know that that is not good. In fact, it's a dangerous practice. And so we do safety planning, which is way more patient-centered and effective. And so when we think about the minimum of what to do, right? So we have someone who's yellow or orange in our practice. First of all, we want to give them the suicide lifelines. Now it's actually 988. That's a national number that just got rolled out. We need to update the slide. I put it in the chat so that people have it. Or maybe I'm not putting it in the chat. So that people have it, but the 988 line is rolled out nationally. So letting people know 988. And what I do is have them put it right in their phone because sometimes they forget, particularly seniors, what was that number, right? So that they have it in their phone so that they can actually do that. And oftentimes I have them call. One of the things we know is that most of the calls to 988 or previously to the Lifeline were resolved during that call. There's very, very few calls that actually result in any other interventions. So I have them give it a call, then they know what happens, right? They've had that experience before. And I will really the Lifeline 988 is evidence-based. It's been shown to reduce suicidal thoughts. It's been shown to save lives and at times been shown to be more effective than behavioral health treatment. It's available 24 hours a day. So it's a really, really super helpful resource for people. And also, I like to give people the Now Matters Now website. It is also evidence-based. A lot of our seniors are online. They're on Facebook. They're on, looking things up on the internet. So they can actually go to the Now Matters Now. What's nice is they can listen to stories so that they can click on people and actually listen to some stories. So Now Matters Now is evidence-based. I will often take them to it right in the office so that they can see it. And again, it's evidence-based. And that is the ability to hear what other people are experiencing and then apply it. And so oftentimes people will report that the Now Matters Now website is incredibly helpful for them. It also gives seniors someplace that they can go, hear a story, click on, maybe answer some questions. And so really, really helpful. So if you give people both of these resources, then they are actually got two evidence-based resources available 24 hours a day that they can take with them right away and use. I also give out the Suicide is Different website, particularly for caregivers, for children. So if you have a senior that's experiencing thoughts of suicide, then this is often a helpful website for those around them so that they can go and be able to get some support. So when we talk more specifically about safety planning, you start to see some safety plans that resemble what we do in fire safety. This is a safety plan that's actually on the Now Matters Now website. And when we think about risk, risk can change. Somebody can go from no risk to high risk in a shorter period of time. And so I had a senior not that long ago, and he had lost his wife recently, within a couple of months. And he was, but he had a neighbor, another elderly gentleman, and they would do things together. And that was really his friend. They had done, known each other for some years. Both of them were widowers, and they had, kind of bonded. And this gentleman, friend of his, unexpectedly passed away. And so he became very suicidal. I don't have anyone now. It's hopeless. I'm here by myself. And so it's really important to teach people what to do if they do become at risk. And I know, we have a lot of people on this webinar. And if we were in a room and I asked everyone, what would you do or what were you taught to do if you caught on physical fire? And pretty much everybody, in fact, everybody as we've gone around all the states has been able to answer this question, stop, drop, and roll. I don't know who taught us that. I don't know when I learned it, but man, they did a good job because we all know it. But nobody ever taught us what to do if we catch on emotional fire. Even though, like physical fire, the likelihood that we would catch on physical fire is low, the likelihood that we're going to catch on emotional fire is low, but we still should know what to do. And a lot of the same things work. Splashing cold water is incredibly helpful. Put your wrists under the sink, splash cold water on your face. being able to not make any decisions, look in someone's eyes, a picture on the phone or a picture on the wall of a family member or a grandchild. Those are all incredibly helpful activities for someone at risk. And remember, if you're on physical fire, you can't necessarily call for help because you need to stop, drop, and roll first, right? You need to do something first before you can do that. So we want people to have some things that they can do when they're on emotional fire so that they can get to the point where they can call 988 or they can call other people that are available for them. We also want to talk to people about means restriction. So means restriction is very important. We want to make sure that we're talking to folks and that it's temporary. This doesn't mean that you're not going to be able to have all of your medication. This doesn't mean that you're not going to be able to go hunting in the fall. It doesn't mean that you won't be able to drive. So it's temporary. And it's also for all my patients. I want to make sure they're safe. You talked to me today about using pills. And so really making sure you're doing that lethal means restriction. It's an important part of suicide safer care. And it's also very important to know the preferred means because one of the things we know is that people don't often switch. So if I can keep you safe from medication, you're not likely to say, you know what, I don't have access to my medication, but I know where the gun is, right? Generally, you don't see that. So I think because it gives people hope. So this lethal means reduction is incredibly helpful and an important conversation to have. And you should absolutely document it in the chart. And also, oftentimes we assume like it might be the medication that we're giving someone, but I ask people, right? So tell me, you talk to me about dying by suicide and using medication. Where would you get the medication? Oh, well, when my husband passed away, I still have all his meds and he was on a lot of meds, so I would just take those. Or asking people how much medication is in your home. Well, it's a lot because my husband will never throw any medications away. And so we actually have a huge bag of medications that are going back for several years. So then you want to try to think about ways to keep someone safe. So when we think about medications, I love Amazon Pill Pack. So why do I love Amazon Pill Pack? Because the pills come in individual packs. We know that if people have to open individual packs, that saves lives. They are sent that way so that they have them right in these individual packs. You can also get medication boxes or lock boxes. So you should really be talking to your pharmacy now. When we care for patients at suicide, can I get, lesser amounts of medication? Do you have lock boxes that we can have? Can somebody come in and pick up partial prescriptions? Can we get the individual wrapping for medications, right? Starting to do some of that now so that you have it and you're prepared to be able to have those conversations with people. And so when we think about safety planning and how to keep people safe, we want to try to identify places or people that they could actually contact to be able to be safe. So who is someone that you think you might be able to call if you're feeling like you're at risk for suicide? And making sure that we put that information down. A lot of times for seniors, it's really helped them to give them an activity or something that they might be able to do, identify something that's helpful. So I often ask, what's something that you could do if you were thinking about suicide that would be helpful for you? Well, it's helpful for me to go outside. And so and then I ask, well, what about going outside is helpful, right? Is it the air? Is it that you see people? Is it that there's things to pay attention to and that it's distracting for you? And so that's an important piece. The one thing to remember about activities is that they need to be something they can do pretty quickly, right? It's not something that only happens one time during the day. Has to be something that can happen pretty quickly. And also all times of the day and all times of the year. So for example, I had an elderly woman, and it was incredibly tragic, lost her family. And she told me that what she liked to do was to go and sit and watch the kids at the daycare down the street from her. And that was incredibly helpful for her. However, she lived in Montana. And so it gets really cold in Montana for those of you who have not been there. Those kids are not out all the time. And that's not something she can do at 2 o'clock in the morning. And so saying it sounds like if the children are outside, then that's something really helpful for you to do. But if the children aren't outside, what's something else that we could do? We could call 988. We could build Now Matters Now. Do we have someone else that we could call? Or is there another activity? So like as an example, you see Walmart in a lot of safety plans. Why do you see Walmart in a lot of safety plans? It's open 24 hours a day. It's available by public transportation. Most communities have a Walmart. So really looking at those and coming up with things that are going to be helpful for people, and then giving them some ability to have them on hand so that they can do things if they start to feel at risk for suicide. And so it's important to remember, and it has to be very specific. So I have, and some of you may have heard, there's a woman by the name of Becky Stoll. And Becky Stoll does an incredible amount of suicide prevention work. Her and her organization are leaders in the field. And she always talks about how she went into like this really, really rural place in Tennessee where she lives. And there was an older gentleman lived out, rural farm, and he had been identified as being at risk for suicide. And she was looking at his safety plan, and it was like journaling and yoga or things that, and she said, no rural farmer, ever senior has, this is not his safety plan. These are not things that he came up with. So they have to be very, very specific. They have to come from someone, what is helpful for you? And then it has to be, so if it's listening to music, what music? So I had someone the other day, an older gentleman, tell me, I listen to Johnny Cash. And I say, well, what Johnny Cash songs, right? Which ones do you like? Do you know how to put them together? How do you listen to them? Well, my daughter put them on my phone for me and I can listen to them, right? Jid actually had a playlist set up for him. And so that was incredibly helpful. So very specific. I'm going to listen to my Johnny Cash, list on Spotify. I'm going to walk down the block and look at the kids at the daycare center. But if they're not there, then I'm going to do this other activity. So these kinds of safety planning activities are really helpful. And if you can give someone, Becky Stoll is the woman who's the leader in suicide prevention. Um, and so you can actually go through with people and give them some very specific things that will help to keep them safe so that they have them. And for your yellow and orange patients, then giving them the lifeline and 988 in their phone, giving them the Now Matters Now website, assuming that's something that they can get to and use. Then giving them some other very detailed things that they're able to do is incredibly helpful. So you've essentially done safety planning, some risk assessment, and your ability to keep someone safe with some of these evidence-based interventions. Incredibly helpful. And for your patients who are yellow and orange, those are actually incredibly helpful, life-changing, life-saving things that you can do during the course of a primary care setting. And when you think about it, just to go back, sort of talking about the patient with asthma as an example, I could come in and I could be having difficulty breathing, maybe having asthma. We would take me back. I might get a treatment, right? You would ask me questions. You would ask me if I use my rescue medication. You would ask me if about any medications. You would ask me about triggers at home, right? Carpet or other, animals, pets. You would ask me about emotional triggers, right? When I got upset, or, were there times of the day? You might give me a referral for pulmonology or for asthma education. You might educate me in the office about how to use a spacer or an inhaler, right? You might or should do an asthma action plan so that I have it, and maybe even share it with others in my home or my caregivers, right? So that people have it and it's available. All those things would happen pretty routinely. So when you think about caring for somebody at risk for suicide, very much the same. Storage statements, assess for risk with the Columbia scale or the ASQ. Yellow or orange patients, do some basic safety planning, giving some resources. Incredibly helpful, can happen right in a primary care practice and during the course of a primary care visit. So incredibly helpful to be able to do that. And so when we think about caring contacts are actually evidence informed. A lot of practices do them. They are really, really nice for seniors who often are isolated and don't often get a lot of mail or don't get things. And essentially, they don't have any demands. So oftentimes, providers will just send a little note. And a lot of times for seniors who might have difficulty reading, maybe it's better to write it in bold or in bigger letters. Really glad you came in today. Glad we had a chance to talk. Hope this note finds you well. This idea of caring contacts actually came out of Australia, where people were getting discharged from hospitalizations, into the outback, and they would send them these caring contacts and they reduce suicides. And so what I think is it gives people hope, and you cannot underestimate giving someone hope. Having your seniors come in and giving them hope is incredibly important and empowering to them, letting them know that you're really important to them, especially since many of their interactions are with healthcare. My mother the other day, I said, well, how is your week going? And she proceeded to tell me about all the healthcare appointments that she had had, right? That was what her whole sort of life was structured around. And so really encourage you to think about the caring contacts. And here's some examples. And I know, from my own practice, I worked in an emergency room, as I mentioned, and worked in primary care for many, many, many years. And when I worked in the emergency room, after I sent someone home, I would write them a little note. Hey, really glad we had a chance to meet. Hope this note finds you well, Virna. And I would mail it off. And I was in the grocery store with my daughter, and this woman came up to me, pulled the note out of her purse, and said, thank you so much for sending this to me. I carry it with me. It's helpful. And I tell you that just so to really drive home, using the right language, asking someone about their suicidal thoughts, giving them some hope can be incredibly impactful during the course of a routine primary care visit, particularly for your seniors, many of whom are struggling with or thinking about suicide. So I wanted to leave a couple of minutes at the end. We have about 5 minutes at the end. To be able to um, answer some questions. I know we answered a few in the chat as we were going along, some that came in private and some that went out to everyone. But I'd be glad to answer any questions or any comments. So one that came in is about liability. So oftentimes I hear from providers about liability and being concerned about liability. And I had a provider tell me, well, that's why I send everybody to the emergency room. But like I said, that actually can be not helpful for people if they don't need to be there with suicide, with anything, right? And so one of the best things you can do for liability is have a system in place. Here's how we care. Here's how we identify our patients at risk. Here's how we care for them. Here's the evidence-based tools that we use for risk. Here's the evidence-based interventions that we give out. Here's some basic safety planning that we do. And we follow that process. And that's the best thing you can do around liability and the most helpful for the patients that you're caring for. Oh yeah, many of my team don't think that patients are at risk for suicide when they're older. Yeah, we actually do forget. Um, so how do you determine when they need to go to the emergency room or not? So if someone has intent, I'm really clear. Lots of people think about suicide, right? Do you intend to die by suicide today? And I ask them, what are your reasons for living? And if they have reasons for living, that is good. If they don't have intent, so you talk to me about your grandchildren, and it's clear to me, I could see in your face, how much you care about them and, how important they are to you. So as your reasons for living and a reason that you wouldn't die by suicide today. So tell me, you also talked to me about suicide and using the gun that's in your home. Do you intend to use the gun to die by suicide today? And if the answer is no, it's really hard. But I know that I'm important to my grandchildren and I don't want to do that to them. And say, well, let's talk about how to keep you safe from your gun. And so it's really important to have that conversation around intent and then to restrict the access to lethal means. Um, is it more difficult to screen or assess when caring for patients with condition? Oh, yeah, that might inhibit their memory or decision making. This is really tough with the seniors. And so one of the things we know is that, certainly risk can change and that it's really hard to do effective safety planning with someone, who's having some memory or cognition problems. And so trying to keep it very simple, trying to make sure that they have access to it, that it's someplace where they'll see it or it's on the fridge or something like that. But yeah, absolutely. And you have to do it sort of patient by patient. But that certainly does make caring for this population more difficult and also makes them, sort of more at risk. Great questions. Thank you. So I know we have about 1 minute left. So I really appreciate everyone's time and attention today. Certainly encourage you to start thinking about your population of patients at risk for suicide. As a population, you can leave here today, put those codes in your problem list so that you can start to track. You can look in your EMR. I'm certain you have either the ASQ or the Columbia scale or both in there built in. You're probably, some of them have safety plans built in. If not, you can do it in the form of a letter. If you want to type it out with someone, you can pull the forms offline at the Zero Suicide website. So please feel free to reach out if there's anything we can do to help support you in this work. But again, I appreciate your time and I wish you all a wonderful day.